Colleagues, welcome back to my channel. Today I am going to discuss a very important topic, that is induction and augmentation of labor. I am going to cover it from Toronto Notes 2025 edition from the Obstetrics chapter. Alright, let's take a start. So, what is the definition of induction of labor? Induction of labor is defined as artificial start of labor, especially that is happening before spontaneous initiation of labor. Okay, so this is a basically artificial initiation of labor before spontaneous initiation to deliver the fetus and placenta. Okay, and induction is indicated when the risk of continuing pregnancy exceeds the risks associated with induction of labor and delivery. So, if there's a risk to the fetus and we want to deliver the fetus and placenta, therefore we do artificial method of start of labor, that is called induction. What is the difference between induction and augmentation? Induction basically means only the artificial start of labor, initiation of labor in artificial manner. But augmentation basically means contractions when basically its purpose is to promote contractions when spontaneous contractions are not sufficient. Okay, so as the mother is progressing in her labor, so contractions, uterine contractions happen to deliver the fetus and the placenta, and if they are not adequate and we want to promote those contractions, therefore we do the method of augmentation of labor. Now, some prerequisites for labor induction: capability for cesarean delivery if necessary. So, they want to tell us that the induction of labor is not always successful, and sometimes normal delivery is not possible. So, we have to sometimes opt for cesarean delivery. Okay, if necessary, if needed. Okay, then the maternal factors, that their mom cervix should be very favorable. It means it should be soft, it should be effaced or thinned, and it should be in the anterior position and dilated. Okay, so the cervix position should be anterior, its consistency should be soft and is thinned and dilated. Okay, and if the cervix is not favorable, and we know the favorability of cervix is can be determined with the help of Bishop score. Okay, so there are 5 points in that score, and so if the cervix is not favorable according to Bishop score, then we have to use certain artificial agents like prostaglandin vaginal insert. Okay, we insert them into vagina, prostaglandin gel or misoprostol or mechanical induction with the help of Foley's catheter or Cook's catheter. So, in order to remember these things, I give you a mnemonic. One is prostaglandin vaginal insert, or one is misoprostol, and the other one is mechanical induction. So, PMM. PMM is basically needed for induction of labor. Okay. Now, the fetal prerequisites are normal fetal heart rate tracing. Okay, the fetus should not be at all be in distress. Okay, and the fetus should be in cephalic presentation, not breech or any other presentation. Okay, and adequate fetal monitoring is available. Okay, then the likelihood of success determined by the Bishop score. If the cervix is considered unfavorable, if the Bishop score is less than or equal to 3. Okay, if the Bishop score is less than or equal to 3, then the cervix is considered unfavorable. But if the Bishop score is more than or equal to 6, then it's favorable. And a score of 9 to 13, that is very much high likelihood of vaginal delivery. So here is the Bishop score that I was talking about. So basically it depends upon the cervical characteristics, the position, the consistency of the cervix, the effacement of the cervix, the dilatation of the cervix, and the station of fetal head. Okay, so this is basically we are going to score them according to 0, 1, 2, 3. Position, the normal position is anterior, and the consistency should be soft, effacement should be 70 or 60 70%, and dilatation So this is extremely normal. This is also somewhat considered normal, and these are on the low grades, lower sides. Okay. So what they say is that a position, if its anterior consistency is soft, effacement is 70 or 80%, dilatation 4 or 5 or more than equal to 5, and station of fetal head if is in plus 1, 2, 3. So now basically that makes a bishop score of what? Bishop score of 6 or more than 6, right? So as a result of that, because if anterior then it's 2 points, soft again 2 more points, so this way we have to calculate the bishop score. Okay, so score of 9 to 13 is associated with a high likelihood of vaginal delivery. Okay, now consider the following before induction. Indication for induction of labor. Now we need to see what do we have all the necessary indications. We have all the contraindications in our mind: gestational age, cervical femoral bishop score, fetal presentation, if there's a likelihood of cesarean delivery, how we are going to manage it, fetal heart rate, fetal well-being monitoring, and membrane status. Okay, now indications for induction of labor. Late term, the most common indication is post-term pregnancy or the late term pregnancy, because when a child reaches term, late term, and still artificial process needed if the spontaneous induction of labor is not possible, so we need some artificial thing to induce the labor. Okay, because a post-term pregnancy has its own complications and it can be dangerous to the fetus as well, or the baby as well. Okay, now, at 39 to 40 weeks gestation, especially with risk factors like advanced maternal age, if the mother age is especially more than 40 years, advanced maternal age, consideration should be given to induction of labor due to increased risk of stillbirth. So we don't want a stillbirth for a mother who has advanced maternal age, and especially she is reaching 40 weeks and still there are no signs of labor. Therefore, we induce the labor to give birth to the child safely. Now, if the gestational age is more than 41 weeks, we offer induction of labor if the vaginal delivery is not contraindicated. Definitely, after induction of labor, if vaginal delivery is possible after 41 weeks of gestation, we offer induction of labor. Induction of labor decreases the rate of cesarean deliveries. It does not show much effect on fetal heart rate and decreased meconium staining, macrosomia, and death when compared with expected management. So we have to do something to make the baby safe. Therefore, we have to induce the labor. Okay, and if the gestational age is more than 41 weeks, expectant management is elected. Serial fetal surveillance is basically needed. So if the mother doesn't want to induce the labor, mother does want a spontaneous labor, mother want nature to do its process, so we have to do expectant management then, and then we have to do fetal surveillance in a timely manner. Serial fetal surveillance is needed. Okay, what we have to say to the mother to do the fetal movements count, and biparatal perimeters of the baby should be checked every 3 to 4 days. Alright, now I am going to read the maternal indications for induction of labor. If the mother is suffering from diabetes mellitus, that is the second most common cause for induction of labor. First cause, do you remember guys? The first cause was late term or post term pregnancy. Second cause now is diabetes mellitus. Okay, and if the mother is suffering from gestational hypertension at more than 38 weeks, definitely we are going to induce a labor. If the patient is suffering from preeclampsia, okay, other maternal medical comorbidities, like if the mother is suffering from any kidney disease, any lung disease, any history of chronic hypertension and cholestasis, significant but stable antepartum hemorrhage, if there is a history of antepartum hemorrhage, okay, definitely we are going to induce a labor. Labor induction may be offered to patient age more than or equal to 40. 40 is the limit. Okay, so if the patient is already 40 years old and the gestational age is more than or equal to 39 weeks, we need to offer induction of labor because there is an increased risk of stillbirth. This point is also repeated before as well. It's very important to remember that if the patient age, pregnant female age is 40 or more than 40, and the gestation reach already 39 or more than 39 weeks, we have to offer induction of labor because there is a risk of stillbirth. Then maternal fetal indications for induction. Okay, what can other can indications can be there, like isoimmunization, preterm rupture of membranes, and chorioamnionitis. So inflammation of the chorion amniotic cavity, infection is there, or there is a preterm rupture of membranes, isoimmunization. Definitely we have to induce the labor. Fetal indications for induction is suspected fetal compromise, hemodynamically compromised fetus, and there is biochemical indications or biophysical profile is not up to the mark. And then the size is very big for its gestational age, macrosomia, big babies. The fetal demise, if death of the fetus occurs in utero, inside the uterus, it is a growth restriction of the fetus. If there is large amount of amniotic fluid, polyhydramnios, or the scanty fluid called oligohydramnios, if there are certain chromosomal anomalies of the fetus and near some surgical intervention, and twin pregnancies, all these are again indications for induction of labor. And previous history of stillbirth or low this enzyme level, then again this is basically indication for induction of labor. Now, the risks. The failure to achieve labor or vaginal birth. Okay, what can be the side effects of this induction of labor? That the labor will not progress, or will not be achieved, or vaginal birth is not possible. Tachycystole with fetal compromise or uterine rupture means the heart rate of the fetus is going to be very high, or there's a risk of uterine rupture as well. Maternal side effects, because these are medications, so there can be side effects to mother as well. And uterine atony and postpartum hemorrhage if labor is prolonged. So the tone of the uterus is compromised, it goes into atony, and postpartum hemorrhage can happen as a result if the labor is prolonged. Okay, now, the contraindications that we need to remember, in these situations, we are not going to induce the labor. The maternal contraindications, some maternal and fetal both together, and then the fetal contraindications. Alright, so maternal contraindications to vaginal delivery include prior classical or inverted T incision. If there is an inverted T incision and there is a classical incision in the previous cesarean delivery, or if there is a history of myomectomy or any uterine surgery, okay, so we are not going to deliver the child vaginally. Unstable maternal condition, they're suffering from some underlying comorbidities, she is unstable. Active maternal genital herpes. Genital herpes again is the contraindication for vaginal delivery. Invasive cervical carcinoma. Carcinoma is again a contraindication for vaginal delivery. Pelvic structural deformities. So vaginal delivery is not possible. Previous uterine rupture, again contraindication for induction of labor. All these are contraindications for vaginal delivery, and in the indirectly contraindications for induction of labor as well. Now, the maternal fetal contraindication in placenta previa. Definitely, placenta previa is very risky. Vaginal delivery is not allowed, is not recommended. Cesarean delivery is recommended. Or vesa previa, again, cesarean delivery is recommended. As I have discussed these things in my previous presentation. Also, there's a cord prolapse or cord presentation. Okay, so cord prolapse or cord, if the umbilical cord is present in the presenting, and if there's a prolapse of the cord, definitely we are not going to induce the labor. Now we opt for cesarean delivery. Then the fetal distress is there, fetal heart rate is not normal, and there is malpresentation of the fetus. The next thing I'm going to discuss is methods for induction of labor. The first method we are going to discuss is cervical ripening. The definition is the use of medications or other means to soften, efface, and dilate the cervix. We are going to make the cervix soft. Effacement and dilatation increases likelihood of successful induction. Okay, the ripening of unfavorable cervix, if the Bishop score is less than 6, is warranted prior to induction of labor. We have to make the cervix ripen because we don't want our induction of labor to fail. If the cervix is not ripened and is unfavorable, Bishop score is very low, less than 6. So we have to do some years to make it a favorable cervix before induction of labor. Okay. The methods used are Foley catheter placement to mechanically dilate the cervix. First line, when feasible, we have to mechanically. So remember, there were a few things that were used for induction of labor. So P, progesterone, then M, mechanical induction, and number three, M was misoprostol. Here they are discussed in more detail. So they discuss that the mechanical is basically with the help of a thing called Foley catheter. Okay, we need to dilate the cervix. Is first line when feasible. Then intravaginal, we are going to insert intravaginal prostaglandin E2 gel, also called the prostin gel. Especially we have to insert it, or maybe the gel is used, and especially useful for long and closed cervix. Okay, and then dosing is every 12 hours, 6 to 12 hours, up to 3 doses are recommended. Then intravaginal prostaglandin E2, again the same indication, gel or a tablet, both of them inserted vaginally. They are basically needed when the cervix is long and closed. It basically results in continuous release, can be removed if needed. Controlled release prostaglandin E2, assess a 12-hour and 24-hour, not used for more than 24 hours. So it's not used for more than 24 hours, only for 12 and 24 hours it is being inserted. Now, intracervical prostaglandin 2 we have to insert inside the cervix. Okay, intravaginal, intracervical. Now, intravaginal prostaglandin E1, that is called misoprostol. Okay, so misoprostol, progesterone, misoprostol, that is long and close. Progesterone and misoprostol both are used. Okay, misoprostol is a inexpensive, stored at room temperature, more effective than prostaglandin E2 for achieving vaginal delivery and less epidural use. So that is more favorable thing is misoprostol. Okay, and this is basically more effective for getting a vaginal delivery, and less epidural use is needed. Contraindicated in the third trimester with previous cesarean delivery. If there is a previous cesarean delivery, so we cannot use it in the third trimester. Okay. Now, induction of labor. Induction of labor can be done with the help of amniotomy, that is artificial rupture of membrane. This is these are the methods for cervical ripening. Okay, so cervical ripening, all these things are needed prerequisites for induction of labor. Now, induction of labor, basically we need to give either oxytocin, or either we have to do the procedure called amniotomy. Let's read about amniotomy first. Artificial rupture of membrane is amniotomy. Whenever we do artificial rupture of membrane, this is called amniotomy. The purpose is to stimulate the prostaglandin synthesis and secretion. So, amniotomy basic purpose is to stimulate prostaglandin synthesis and secretion. May try this as initial measure if cervix is dilated and soft. Okay, the membranes can be felt, and if the head is well applied to the cervix, if the side is very much close to the cervix, and secondly, if the cervix is very much dilated, cervix is very much soft, and we are feeling the membranes, so we can do artificial rupture of membranes, and the advantage will be the labor will be basically induced in such a way. Okay, and the few studies address the value of amniotomy alone for induction of labor. Okay, amniotomy along with IV oxytocin, if it's given together with oxytocin, more patients delivered vaginally at 24 hours than amniotomy alone. So amniotomy basically along with oxytocin, that can help in vaginal delivery rate to increase, and had fewer instrumental vaginal deliveries even. Okay. Now oxytocin, let's talk about oxytocin. Oxytocin 10 units in 1 liter of normal saline, and run at this rate increasing by 1 to 2 milliunits per minute every 20 to 60 minutes. We don't have to remember the doses exactly, just we need to have a rough idea that oxytocin should be given in 1 liter of normal saline 10 units initially, and then reduces the rate of unsuccessful vaginal deliveries within 24 hours. So within 24 hours we have to, if we give the oxytocin, this will reduce the risk of unsuccessful vaginal delivery. So vaginal deliveries will be possible, it will be successful. Okay, when used alone, our ideal dosing regime of oxytocin is not known. We have to increase the dose according to the patient response. Okay, now the current recommendations use the minimum dose to achieve active labor, increase every 30 minutes as needed. So the basic recommendation is that we have to use the minimum dose to achieve active labor, and then increase every 30 minutes as needed. Reassessment should occur once a dose of 20 units is reached. Reassessment should occur when a dose of 20 international units is reached. Okay, caution is needed in patients with previous cesarean delivery or uterine surgery. Definitely, if we have a history of previous cesarean delivery, now we are doing way back that vaginal birth after cesarean, or there is a history of uterine surgery, definitely precautions is needed. Okay, we need to be very much active, and we need to monitor the labor very promptly. Provided there are no contraindications, oxytocin is used to improve uterine contraction strength and or frequency. So basically, the basic purpose of oxytocin is to improve uterine strength and or contractions. Okay, now contraction strength as well as frequency. Okay, now no earlier than 30 minutes post intervalle removal. Okay, but they are saying that when we are going when we provide oxytocin to the patient, after that no earlier than 30-minute post intervention removal, 6 hour post in gel insertion, and 6 hour. Okay, so we will have to give prostaglandin only after this. Okay, if we have prostaglandin E2 gel 30 minutes after that, we can give oxytocin. 6 hour after that and 4 hour after that we can give oxytocin. Potential complications, so both these things should be used one by one. Okay, then the potential complications, but amniotomy and oxytocin, they can be done together. Okay, the amniotomy, we do the amniotomy and we start oxytocin, that can be done together, but these things we need to wait for a certain time, then we can opt oxytocin. The complications of oxytocin use is tachysystole, increase in the heart rate of the fetus, tetanic contraction can happen resulting in fetal distress or uterine rupture, that is quite serious complication. Okay, then uterine muscle fatigue can happen, atony can happen, uterine atony, and that is a major cause of postpartum hemorrhage. Okay, so uterine atony can happen leading to postpartum hemorrhage, uterine rupture can happen, fetal distress or demise can happen, vasopressin-like action causing antidiuresis. It can have a vasopressin-like action and can cause antidiuresis. Okay. Now the augmentation of labor. The augmentation of labor with amniotomy or oxytocin may be used to promote stronger and more frequent we have to basically augment the contractions, so we have to use amniotomy and oxytocin together when spontaneous contractions are not adequate and cervical dilatation or descent of fetus fails to occur. So for augmentation of labor, we have using the same thing. We are doing amniotomy. We are using oxytocin. They are not only meant for after induction of labor. We do these things to promote more and more contractions, powerful and strong contractions that can help in easy delivery of fetus and placenta, and also help in cervical dilatation and descent of fetus. Okay, so I'm signing off for now, and I'm going to soon cover some few other topics from obstetrics, and see you soon in our next video. And if you find these videos useful, please give a thumbs up, like, subscribe, and share. Thanks, and have a great day. Take care. Bye.